How is neuromyelitis optica, NMO, different from MS? Imagine two diseases that both attack the nervous system but do so in very different ways. Neuromyelitis optica and multiple sclerosis are both autoimmune conditions that cause inflammation in the central nervous system, but their causes, symptoms, and treatments are quite distinct. Neuromyelitis optica mainly targets the optic nerves and spinal cord. It often causes severe inflammation of the optic nerve, leading to sudden vision loss and inflammation of the spinal cord, which can cause weakness, numbness, or paralysis. These attacks tend to be intense and can cause significant disability early on. In contrast, multiple sclerosis affects a wider area of the central nervous system, including the brain, spinal cord, and optic nerves. MS symptoms are more varied, such as sensory changes, muscle weakness, balance issues, and even cognitive problems like memory loss. The optic neuritis in MS is usually less severe and often affects one eye at a time. When it comes to how the diseases progress, MS often has a pattern of relapses and remissions. Some people recover fully between attacks, but over time, they may experience gradual worsening of symptoms. Neuromyelitis optica usually does not have the same relapsing pattern. Instead, the severity of attacks causes most of the damage, and between episodes, patients might not see much change. This means early diagnosis and treatment are crucial to prevent lasting damage. A key difference in diagnosis is the presence of specific autoantibodies. In NMO, about 70 to 80% of patients have antibodies against aquaporin 4, a water channel protein in the brain and spinal cord. These antibodies help doctors distinguish NMO from MS. In MS, no such specific autoantibodies have been identified, so diagnosis relies more on clinical signs and MRI scans. Sometimes, NMO patients do not have the aquaporin for antibodies, which can make diagnosis trickier and requiring additional testing. Imaging also shows differences. MRI scans of the spinal cord in NMO reveal long, continuous lesions that extend over 3 or more vertebral segments, often located centrally within the cord. In MS, spinal cord lesions are usually shorter, patchy, and located more on the outer edges. Brain MRI in MS often shows multiple scattered white matter lesions, while NMO brain lesions are less common and tend to have specific patterns, like around the ventricles or in certain hemispheric areas. Optic nerve damage is more severe in NMO. Optical coherence tomography, a test that measures nerve fiber layers in the retina, shows that optic neuritis in NMO causes more extensive thinning and nerve cell loss compared to MS. NMO can also cause swelling in the retina called microcystic macular edema, which is rarely seen in MS. Interestingly, people with MS may have some retinal damage even without optic neuritis, but this is uncommon in NMO. Demographically, NMO tends to affect women more than men and often appears later in life. It is found worldwide, whereas MS is more common in regions with temperate climates. The differences in who gets these diseases and when they appear help doctors narrow down the diagnosis. Because NMO and MS are different diseases with different underlying causes, their treatments vary. Some medications used for MS can be ineffective or even harmful in NMO, so accurate diagnosis is essential for choosing the right therapy. In summary, although NMO and MS share some symptoms like vision problems and nerve issues, they are fundamentally different. NMO mainly targets the optic nerves and spinal cord with more severe attacks and has specific markers like aquaporin for antibodies. MS affects a broader area of the brain and spinal cord with a relapsing-remitting pattern. Recognizing these differences helps ensure patients receive the most appropriate care. Always consult healthcare professionals for personalized diagnosis and treatment options.